Hello everyone, I am Dr. Akash. From today, I'll be starting a new video series that is Orthopaedics for Neet PG. I'll be covering most important topics of orthopedics which are very important for Neet PG. So, as per request, we'll start with the bone tumors. The chapter of bone tumor is very vast, so we'll try to make it in parts. And today I'll be covering basics of bone tumors and some important benign ones. So let's proceed. What is bone tumor? So you can remember the definition, but simply the tumors arising from the bone itself. So what are the nature of bone tumors? It can be divided into benign or malignant ones. And according to the source of origin, it can be divided into primary or secondaries. Secondaries basically mean the metastasis. What are the types of metastasis that we see? We see either osteoblastic, osteolytic, or mixed. In cases of some tumors like prostate cancer and in cases of lung cancer metastasis, we see osteoblastic ones. And in case of thyroid or renal metastasis, we see mostly osteolytic ones. And in case of lung metastasis, we mostly see mixed ones, and in some cases of breast metastasis as well. And the secondaries or the metastasis is the most common tumor overall. Now let's see the difference between the benign tumor and the malignant tumor. First, let's cover the benign one as compared to the malignant ones. The benign tumors are smaller and these are slow growing, non-invasive, well differentiated, and they stay localized to where they are, and they basically don't invade or metastasize. But as compared to the benign counterparts, the malignant tumors are larger, fast growing, invasive, poorly differentiated, and they usually metastasize. They try to infiltrate, invade, destroy the surrounding tissue, and they can metastasize to other parts of the body as well. So let's see the histological differences between the benign and the malignant neoplasms. Let's cover the benign one first. It consists of well differentiated cells, and the cells are rather uniform in size and shape. And if we see in the staining, the nucleus take up the stain normally. There are few mitoses, there is decreased nucleocytoplasmic ratio, and the cells do not infiltrate. So basically you can see these benign tumors, they resemble mostly the parent tissue from which they are derived. But in case of malignant ones, there are nuclear polymorphism, there is increased nucleocytoplasmic ratio, there is loss of polarity, that means numerous multipolar mitosis is in, and these cells do infiltrate, and this can metastasize, that we have already seen from the previous slide. Now let's see what are the types of lesion radiologically we can see. First, let's see geographic lesion. As the name suggests, as in geography we have studied many states and countries, they have a certain defined boundary. So they have the well-defined lesion, and aggression wise these are least aggressive. One example you can remember is simple bone cyst. We'll cover everything afterwards. The second one is moth eaten. Like the larva of the moth eats some leaves of some trees, so these are less well differentiated with a moth eaten appearance. These are slightly more aggressive than the previous ones. So you can say the giant cell tumor or some cases of low grade osteosarcoma come under this category. Then there comes the most aggressive one, that is the permeative lesion. Permeation means the tumor has basically spread to the surrounding structures. So you cannot tell exactly where the boundary is, so these are least defined. So the most aggressive variety, you can say telangiectatic osteosarcoma, can come under this category. Let's see the radiological pictures. As we have discussed, the first one is the geographic one. Can you tell the example? Yes, it is simple bone cyst. Now as you can see in the picture below, the moth is eating some leaves, and in the X-ray you can see there are some areas which look like being eaten up by the moth. And what was the example? Yes, it is the giant cell tumor. And let's see the permeative ones. So as you can see, you can barely say which is the cortex, which is the medulla. There is loss of the corticomedullary differentiation, and the telangiectatic osteosarcoma comes under this. So as we have studied, the permeative one is the most malignant and the geographic ones are the least. Let's see what's the classification according to the tissue of origin. We'll first see. Let's see the bone forming ones. So they will be classified into some benign ones and some malignant ones. The benign ones are osteoma, osteoid osteoma, osteoblastoma, and the malignant one is osteosarcoma. Then comes the cartilage forming tumors. Let's see the benign ones: chondroma, osteochondroma, chondroblastoma, and the malignant one is chondrosarcoma. Then there are fibrous tissue, fibroma, fibrosarcoma. There is giant cell tumor. There are other tumor you can remember for your exam purpose. Let's move ahead. There are some lesions which behave as tumor but not tumor exactly. So what are those? Those can be bone cysts. This can be simple bone cyst or aneurysmal bone cyst, or ABC. There can be some fibrous dysplasia. It can be either monoostotic or polyostotic. It can be fibrocortical defect, or it can be eosinophilic granuloma. Let's see the classification according to the location. This is very important. At first, look at the picture which is on the right side. First, let's see according to the location. First, see the benign ones. From the epiphysis, there occurs chondroblastoma and the giant cell tumor. You can simply remember with a mnemonic of ECG. That is, from the E, that is epiphysis, there comes C, chondroblastoma, and G, giant cell tumor. What's the difference? You can see from the X-ray picture which is on the side, there is the chondroblastoma, but the GCT and chondroblastoma has basically the same site of origin, but why they have mentioned it as chondroblastoma, not giant cell tumor? You can see there is still the growth plate, you can see in the tibia and femur. So the basic difference is, before the skeletal maturity, when you see a epiphyseal tumor that is mostly lytic and or sometimes mixed, it is chondroblastoma, the epiphyseal tumor. And after the skeletal maturity, you basically see the giant cell tumor. And what is the classic radiological appearance of giant cell tumor? Yes, it is the soap bubble appearance. So as this skeleton is skeletally immature, this is mentioned as chondroblastoma. Let's move ahead to the metaphyseal tumor which are benign. There is osteoblastoma, osteochondroma, non-ossifying fibroma, osteoid, osteoma, chondromyxoid fibroma, and in some cases there is the giant cell tumor in case of skeletally mature patient. But as you can see, the giant cell tumor has been mentioned both in epiphysis and in metaphysis. Why? Because mostly the giant cell tumors, they arise from the epiphysis, but when the giant cell tumors are diagnosed, they have already spread to the metaphysis. So nowadays some definitions say that the giant cell tumor is epiphyseal-metaphyseal, so you have to remember. Then in the diaphysis, you can see enchondroma or fibrous dysplasia. Then comes the malignant tumors. In the diaphysis, you will see Ewing sarcoma and chondrosarcoma. In the metaphysis, the most common is osteosarcoma. So let's cover some of the important benign tumors today. Let's start with the osteoid osteoma. It is the commonest true benign tumor. You have to remember the word true. Why? We'll come to this later. There is a nidus of tangled mineralized osteoid elements which is surrounded by some sclerotic dense bone. The age of presentation is usually between 5 to 25, but it's commonly seen between 15 to 25. It is mostly seen in femur, tibia, lower extremity. It is more common as compared to the upper extremity. And the site is mostly, as we have discussed, the diaphysis of long bone. Sometimes we see in the posterior elements of the vertebra. So what's the clinical presentation? The classic clinical presentation of osteoid osteoma is there is nagging pain which is worse at night and are relieved by salicylates or the NSAIDs. This classically comes in your MCQ questions. But why this pain is relieved by salicylates? Because the nidus of osteoid osteoma, they produce prostaglandin in high amount, and as the prostaglandins are some inflammatory mediators, they cause pain. And when you will touch the part where there is swelling, there will be tenderness at the site of the lesion. Swelling may be present, may not be present. That makes the diagnosis confused. Now comes the investigation. In X-ray, you will see a radiolucent nidus at the center surrounded by a zone of sclerosis. X-ray, we can be better, like now you can see the X-ray. You can see there is at the center, first look at the picture above, there is the central nidus which is radiolucent. Surrounding that, there is a zone of sclerosis. The picture below the X-ray is a CT scan picture. You can clearly see there is a nidus, right? Now you can see from the bone itself, there is a nidus. There is a surrounding sclerosis. Now you know from these surrounding there occurs some secretion of the prostaglandins which cause pain. Now comes to the treatment. As we have already discussed, the pain is relieved by salicylates, mostly aspirin, but aspirin has its own side effect and these are only symptomatic. So if you will be asked about the treatment of choice for osteoid osteoma, the answer is radio frequency ablation technique. Now comes the surgery. So when the symptomatic relief is not achieved by all this conservative management, you have to go for excision of the lesion along with the nidus. Along with that, you have to add curettage to it as well, but it has a good prognosis. Now comes the osteochondroma. What's the common name that you know of? That is exostosis. Like we studied before, the osteoid osteoma, we called it as most common true benign tumor, but the most common benign tumor of bone is osteochondroma. Why it is not a true tumor? Now the question comes. So basically how it originates. So as you know, in any bone there are some growth plate which give rise to the length of the bone and they grow rapidly. Sometimes what happens is there are some cells of these growth plate which are left out in the metaphysis, and as far as the child is growing up until the skeletal maturity, which comes at around 18 years, so these cells continuously grow, and thus these tumor, they grow up until the skeletal maturity and then stops. That's why we cannot call it a true tumor. So this basically is the hematomatous proliferation of the bone and the cartilage in that area. So your homework is, you can say in the comment section, what is a hematoma and what is a choristoma. Then, as we have discussed, there is a continuous growth of this up until the skeletal maturity. Thus, it is not called a true neoplasm. There is another theory of this, is that there occurs some herniation of the growth plate into the metaphysis, and these give rise to the osteochondroma. The interesting part about the osteochondroma is that they grow away from the joint line. You have to remember that in X-ray also you can classically see this thing. Coming to the clinical aspects of this, most of the osteochondroma are asymptomatic and painless. We often see hard mass on long bones around the knee joint. These basically sometimes present with mechanical problems. The symptoms are usually less. These are mostly asymptomatic, but if they will complex some nearby neurovascular structures, then they can cause pain, and the causes of pain can be related to all the complications which are associated with the exostosis, which we'll cover later. The age of presentation is classically between 10 to 20 years, and during the growth period, as we have discussed. What is the site of osteochondroma? It is the metaphysis. You can see from this picture, you can see the blue part, the yellow part, and the pink part. The blue part is the cartilage. So this whole growth is surrounded by a cartilaginous cap, and there is bone below that, and there is the bone marrow below that. So what basically I'm trying to tell you, that when you do an X-ray of a osteochondroma, what is the difference in size? The answer is, whatever radiological size you get, in actual tissue the size is always more, because this cartilaginous cap you cannot see in X-ray. Now this was a real patient in our ward, so you can see mostly these are asymptomatic and painless. You can see sometimes it is associated with some hard mass. Now coming to the investigation. Now, as we have discussed, these grow away from the knee joint. In the picture A, you can clearly say the head is going away from the knee joint itself. So as I have told you before, that the cartilage gap is not visible, so the actual size is more than what you see in the X-ray. And there is some differentiation. The first one is the sessile type, in which the base of the tumor basically blends with the metaphysis, and sometimes these are pedunculated one, which has a stalk. And you can clearly say from picture A and picture B, which is sessile, which is pedunculated. You can mention that in the comment section. Now coming to the complications of osteochondroma. This is a very important question considering your MCQ, along with that your final MBBS exam. When do osteochondroma cause pain? When there is some complications associated with it. What are the complications? First one is bursitis, pathological fracture, neurovascular symptoms due to compression of some surrounding neurovascular structure, like when there will be osteochondroma from the neck of the fibula, it will be compressing the common peroneal nerve, causing some pain and foot drop as well. Then there will be restriction of the joint movement, and then sometimes it can change to the malignant transformation. What are the malignant transformation? You have to tell that in the comment section. Now coming to the treatment part. You have to excise the tumor along with its periosteum. You cannot leave behind the periosteum. What are the indications of surgery? These are when the osteochondroma associated with the symptoms like pain and all the complications, and sometimes when there is cosmetic problems. Now coming to multiple hereditary exostosis. Unfortunately, this is a severe type of exostosis, which is seen in hereditary conditions in which you will find multiple exostosis. There is development of multiple benign exostosis at the end of long bones, mostly in the lower extremities, but it can also be found in upper humerus or forearm bones like radius and all that. You can see from the picture itself, this is very problematic considering the treatment and the complications. 5 to 10% of the multiple hereditary exostosis, they go into malignant transformation, mostly into chondrosarcoma. The more the proximal the lesion is, the more the likelihood of malignant transformation is. What's the treatment? We can treat it by excision of the symptomatic lesion, then we can follow up the patient. Now there is some homework. You can say the answer in the comment section. If you find any difficulty, you can let me know. What is Ollius disease? What is Maffucci syndrome? What is periosteal reaction? And what are the types of periosteal reaction? Thank you so much. We'll be covering all the bone tumors in the subsequent episodes, and really thank you so much for your time. If you want any subject in particular, you can also mention that in the comment section. Thank you.